The final segment and the last one would be the clinical applications. Now we're kind of all, hopefully, all converted. They say, yeah, 3D, there's a lot of scope. We need to get to 3D now because 2D is not giving us enough. So the clinical applications of CBCT would be my last segment. I would take maybe another 10 to 12 odd minutes. Dr. Akshata, is that all right?
Yes, sir. So you've made it so interesting that I'm sure all the attendants are hooked to your presentation.
Fine, okay. So if it's okay, I'll go to my last clinical applications of CBCT. I've got a lot of people asking me saying, can you do implants? Can you do a lot of things? But trust me, so for the center, really, the center sitting there giving you reports, they're actually doing this hard work behind. But I just go through a few, maybe for implant, maybe a little in detail, and the others we'll just look at some case reports, some case scenarios, just to prove my point that yes, CBCT can be used, and literally every single department can probably think of using CBCTs even on a day-to-day practice. So I look at some case scenarios a little later, but I think a little emphasis, maybe about 3-4 odd minutes on implants. Otherwise, the applications are pretty much the same. You're just looking at bone loss, you're looking at fractures, so just the application would change. Okay, a little bit on implants because trust me, for an oral medicine person, implants just doesn't interest us because it's like measuring a lot of things. Maybe a prosthodontist would just love this information, a surgeon would love it, a periodontist would love it, but a maxillofacial radiologist just hates to report implants because it's a lot of measurements. And honestly, we don't have any fun doing it. But then there are some rules to it, and these rules we learned from prosthodontists, and we learned from surgeons, we learned from periodontists what they want, right? So let's look at implant planning. I'm using a different software here. However, at the end of my lecture, you'll be introduced to the software Chesa uses. But just let's look at, these are great because unfortunately I'm the academician. So I just want you to just go through some recommendations very quickly by the American Radiology Association. So what they say is, for some reason, they still believe PAN should be the first initial evaluation. So when you get a patient, it makes a little sense to me too. I'll tell you why. We all have this habit of, hey, patient comes to me, a couple of missing teeth, go for implant. Yeah, it's nice. But the problem with that is you have no idea, you have no inkling of what's the status of bone around. Is this patient meant for implant? It's not it's not, should I say, the end. Once you get a CBCT, yeah, my job is done. It's not there. You have to be sure that the reason why you're sending for CBCT is to plan your implant. And that planning would start with a PAN because it's telling you what's the status of bone around. Is this patient who's diabetic, is the bone around okay? Because you know of this thing called a wandering abscess in diabetes, where the periodontal tissues are compromised every other day. One day the maxilla, the other day the mandible. You'll just wonder, hey, what's wrong? The bone looked great today. Then you place an implant, and a couple of months or years down the line, it fails. Nothing wrong with the CBCT. It was fine that day. It was about your planning. And that plan should start with a PAN because it's going to give you the status of the periodontium. So start there. If required, if you're very concerned, look at an IOPA for that single site and then go for CBCT. Okay. So, and you always ensure that the implant site should have cross-sectional imaging, and that your center will give you nothing to worry. They know exactly what to give you. And then you follow up your patients. Okay, so we will look at this. No, fine. Last point, very important. I'm again emphasizing that. You know, all these implant patients have periodic reviews. Again, not a great habit to review them with CBCTs because yes, less exposure, we all agree, but don't use it for frequent review for asymptomatic implants. I've absolutely no issue with it. Just let it be. Okay, fine. Then, so what are the steps? The first step you do is you're looking at the facial and cervical tooth position, you're looking at the space around, and mainly the bone configuration and density. Everybody talks about, is this bone quality good? That's what we need to discuss. Okay, so start with on implant windows, you're normally looking for PAN first, then you decide your cross section, Also look at it in the axial section where exactly you want to place this implant. So the first step would be is drawing a panoramic contour. So it means you will, because you don't have a pan here, you're doing working on a reconstruction, right? So you get an axial image, and then the software will show you where to draw these panoramic contours. One, you have an automatic contour line. The software that you're going to use soon also has it, but you also get to draw it yourself. You can draw one. Then you trace the nerve. Then you check what's the mesiodistal width of the tangential span. Amongst that, you choose a nice cross section saying this is where I'm going to work. Okay, at that cross section, you check the superior inferior height. And there, your job is saying, yes, this height is great, but how close is it? Is it close to the mandibular canal? Is it close to my nasopalatine canal? Is it close to the maxillary sinus? Is it closer to the lingual foramen? That's where you check proximity. And finally, you check the buccolingual width of the implant site. If you do this, then you plan your implant with a crown. Okay, the first step would be you're drawing a panoramic contour. I'm doing a different software. You don't worry too much. So what you're essentially doing right on the top you see is you will draw a panoramic contour. You have an axial section. You have an axial section there, and you're just drawing a panoramic contour line. If you do that, you'll get a panoramic image. The next step is to nerve trace. Okay, because you do not want the, especially if you're, I mean, nerve tracing, especially if it's mandibular canal. You do not want the implant to go sit on the canal. So what you would do next step is go through the panoramic, after you have a panoramic image, look at various cross sections and start to identify, okay, that's where my mental foramen is. I start to trace, and then I would get a nice nerve tracing done. The next step after that would be is checking the mesiodistal width, like I told you, between the tooth available. You'll say, okay, from this premolar to the molar, this is a space available. You look at both the height of the tooth there, because ultimately a crown needs to go. And you're also looking at the mesiodistal width of that edentulous span. So that also needs to be assessed. Right. And then after you do that, the question is, where is my implant? Yes, I know this is the width. It's 8 mm there, it's 10.4 there, but where am I going to place it? Ultimately, you will pick a midpoint of that edentulous span. The midpoint is generally the ideal location of that plant, of the implant. Okay, after you do that, there are certain guidelines, thumb rules you have to follow. And this your diagnostic center would do. There are certain guidelines for the implant, sorry, not to fail. From implant to the tooth, it should be about 1.5 mm. An implant to a vital structure should be 2 mm. Implant to implant, if there are two implants, there should be roughly about 3 mm gap there. And from implant to the facial lingual bone should be about 1.5 mm. If you don't have this area, if you don't have all this free space available, trust me, there's no way you can place the implant. So these guidelines are important, okay? And then after you do that, okay, that's what we said, the minimum distances should always be maintained. Then you can choose your implant. Let's get into, okay, that's a lot more detail. Let's look at the superior inferior height. This is very, very important. Always remember you have these things looking at you on your face when you place an implant. If it's anteriors, look out for floor of the nasal cavity. That could be the closest landmark. You don't want to get there. If you look at maxillary posteriors, look for floor of maxillary sinus. If it's the lingual side, the mandible anteriors, you look for the lingual foramen. And finally, if it's the mandibular premolar molar region, look for the mental foramen, of course, the mandibular nerve. Very important structures to look for. That's what is a proximity I told you, right? So now let's take this one small case here. If I have to look the nasopalatine canal, I wish my, yeah, right. See that this is the guy. This is where the implant site is planned. The distance is about 2 mm, right? So you know this is what you need to understand about the anatomy and say, okay, now I have 2 mm there. Can I use this place? Similarly here, this is the nasopalatine canal here, right there. So this is no place for an implant. So you move it away slightly posterior. This is the nasal floor. Around this area, you have roughly about 11.4 mm. Maybe this is a good site. Okay. So watch out for those. Similarly, for the maxillary sinus, that's the floor of the maxillary sinus. you need to look out for all of these structures. The lingual foramen there, you look at that lingual foramen, that's the mandible anterior region. So from the crest, you're walking down up to the lingual foramen. This is where the nerve enters, and that's where you'd stop. Like I told you, if I have to again make this mention again, always overestimate, always. Though I spoke about isotropic voxels, trust me, there is some magnification. So overestimate. Right. These are all structures. Let's not. We've understood how important it is. You look at the structures, and then you look at the buccolingual width of the bone. This is what it is about looking at the buccolingual width. Now, what we do in our dental school is we do this every 1 mm. I think it's a very safe bet. If you're a little lazy, you can go to 2 mm, but it's always nice to give measurements every single mm. It gives the surgeon, it gives the prosthodontist some amount of flexibility, wondering what exactly, how the implant should be placed. So give that width of bone every 1 mm, from top to down, width of the bone every 1 mm. Remember that. And then, of course, each of the softwares are different. You have a implant library, or you can actually pick the implant and then place it there. That's called virtual implant placement. So you can just position the implant there. So that was after the nerve tracing is done. So you get that nice nerve tracing done there. Okay. Then you place the implant with a crown. Now, the most important thing we all need to understand is looking at bone density. We all agree the Hounsfield units, the HU, that is seen on the software is not really Hounsfield unit like the CT. That's the only big change I think with CT and CBCT. You can literally rely on the CT HUs, but not on CBCT. So what we generally go with is the most popular. I should just go to Mishra's classification. D1 to D4 bone. This all available here. What's a D1 and D2, D3? So essentially, you don't do D1, D2. Just close your eyes, place implants. D3, D4, you're actually thinking twice. Is it okay? Not okay? D4, I would say no. Between D2, D3, okay, but D1 and D2 is pretty okay to place bones. I just like you to take you to just one aspect here. This is something that if people are not aware, I think you should look up literature. There's a wonderful thing recently given by Howe et al. He talks about D1, D2, D4 on CBCT HUs. So maybe you can look up that. That makes some sense. 600 to 200 to 600 and lesser than 200 HU. That's the closest you can get to CBCT HU studies. Maybe you can rely on this. Okay. So that's on density. Let's not. Okay. I think the software that you will also be using has this wonderful tool of looking around what's the density of bone. The software, the machine that Cheza has also tells you about the density of bone around the implant. That's a wonderful tool to have. Right. Some advances now is you could also use CBCT for like guided surgery. You could literally, this is wonderful to have guided surgery. It's more like an advancement now where you can use a 3D printing, create stents, and when the surgeon places it, he knows perfectly. These are called drill guides. You know exactly where exactly to place the implants. Okay, this can be fabricated. Labs could do that for you. Okay, and then of course you do a post-operative implant assessment to see it taken up or not. That we can skip that. Okay, so CBCT can also be used wonderfully well in endodontics, the other applications now. These funny things keep coming up. A lot of endodontists love to use CBCT because you begin to see these aberrations that you see. Now you see a molar with two roots, the maxillary especially, so that's very surprising. Then you see that MB canals, the endodontists just love the MB canals if you spot one for them. So CBCT does all this for you. Cannot see that on simple periapicals. Of course, a lot of aberrant anatomy we see. That's endodontic treatment, diffuse radiolucency at the apex, probably a periapical scar maybe. But then CBCT will tell you, hey, there's another route that you did not see on IPA. So that was not obstructed because nobody knew it was existing. Okay, so suddenly a diagnosis would change from just a scar to saying, hey, no, it's an abscess, redo again. So that's a supernumerary root tooth. Look at the configuration of a C-shaped canal. And then, of course, a lot of periapical pathologies, what could detect a granuloma. You can measure the distance. So those are all great tools to use. Okay. A lot of cases. So just skip that. Fractures, internal resorptions, external resorptions. You see a lot of resorption happening there. The apex is resorbed. You could see that on 3D reconstruction. Great. I have a lot of case reports I want to discuss, but just this maybe. Yeah. So we had this patient, 51-year-old. This tooth was actually restored. Okay, and this guy had a lot of pain, almost like 2 weeks. And the IOPA showed us a nice diffuse radiolucency at the apex. But then we took a CBCT because we're wondering what to do, whether to extract, do an RCT, and then it shows a lot of things. Now, suddenly we realized there's a huge, nice, more like a polyp now sitting there, and maybe an insight, an inflammatory response there of the apex causing this big thing. And ultimately turned out he needed an ENT surgeon to involve here just because of this small, tiny tooth there. Okay, so you see that polypoidal growth there that you see. There's a breach in continuity of the sinus. Okay, that was odontogenic. This is again academic, I won't get there. You could see patency of canals, calcified canals. Oh, that's lots. Okay, that's, no, I think we'll just skip that. Orthodontic assessment again, you could see facial symmetry. You could see for soft tissue analysis, impacted teeth, and a lot of studies that happen now in orthodontics. You get a virtual Ceph. All machines have this virtual Ceph. You have something called programs to check for orthodontics. You could do measurements to check for facial asymmetry. Literally, I should say, none of the orthodontists now literally stick to lateral cephalometry. They literally do all those kind of analysis virtual on 3D models and on the CB using the CBCT machine. Okay, they also use it for checking intrazygomatic implants. Periodontics, you could see furcation involvements like never before, literally. I should just mention here when I go to airway space analysis, I'll tell you probably that there you could see these intrabony defects that are there around the tooth causing perforation of the plates. You see that plate perforated here, right? Now, course for impacted molars, I mean, surgeons, third molars surgeries will help you. You could actually skim images, will get to literally showing you where the tooth is positioned, right? You can actually literally see. Also great education tool for patients. This is showing you again canal, which is marked here, and you actually trace the canal on the cross sections. So multiple uses. Yeah, airway volume assessment is again something new. We have now a lot of the other, should I say, even for a lot of diagnostic centers is to check with sleep clinics, the pulmonologists. A lot of them refer for airway analysis, especially with OSA, obstructive sleep apnea. And the reason why I'm emphasizing here is including the Chesa equipment that you have now have tools to identify, mark airway. This same tool can be utilized by periodontists to mark how much of bone needs when the bone is lost. You can actually mark the area and say, okay, so much volume of bone is lost. So that will help you, including cleft palate surgeries, help you with deciding how much of bone is required, the material that you use. You can say, okay, this is the volume of bone I need to fill that defect. Okay, same thing here for cleft palate. We mark the area saying how much of volume of bone is lost there, and that will help the surgeons plan how much of bone is required for for placement there. Good diagnostic tool for fractures. So that's again an occlusal and IOPA showing you these, you see a fracture line there. But this tooth looks very, just a typical 2D imaging, shows you nothing at all. But on a CBCT, you'll be surprised to see there's a fracture at the root surface. Yeah, this is all very obvious, right? You see the fractures, both sides condyles, very, very simple fractures. But the CBCT shockingly reveals, will tell you there's a symphyseal fracture too here along with these, right? That was not caught on the 2D imaging. This patient had just gone away. Then CBCT shows you that. So again, a lot of use. Sinuses shows you a lot of, yeah, just one point here. This is for sinus view, showing your coronal view of carcinoma of the maxillary sinus. I remember Shilika just asking me if something can be spoken on mucormycosis. Honestly, mucormycosis is just a pathology that causes extensive destruction of bone. So I wouldn't say there'd be any difference between seeing a CAS carcinoma of the sinus or the palate and a mucormycosis. They're probably just the same. And osteomyelitis also would look like that of the palate or of the midfacial region. So all you would see is just extensive destruction of the maxillary bone, even in mucormycosis. So that's a picture of carcinoma of the maxillary sinus. In the last 1 year, I saw a couple of case reports mentioning mucormycosis, but nothing to take from there because they just mimic every other destructive lesion, just like CA. So you have to have pick two CBCTs of carcinoma or a mucormycosis. I wouldn't know the difference. I'll just say there's extensive destruction. I'd probably put them in one of the differential diagnosis. That's for TMJ evaluation. You see wonderful for arthritis of you see condyle, you see a lot of destruction there happening, erosion of the condyle, condylar heads, right? So hyperplasia, I was speaking about enlargement of the condyle, arthritic degeneration, so all that is possible. Yes, so what's the limitation? I think the biggest limitation is one, general dental practitioner just wondering, hey, is it too expensive? Do I need it? Yes, maybe. But over the years, I've seen they're not really as expensive as you want it to be. But the information you get from CBCT is much more than any 2D imaging. And how would all that translate to better patient care? Second, the biggest fear factor is knowledge and awareness. There are loads of training programs, a 1 hour program or 1.5 lecture like what I was doing just now. There are lots of these awareness programs. I think you should just go and attend as many as you can. The small problem with soft tissues, you can't see much. So a point here to add, just one when I was talking about trauma, CBCT is good for trauma, but when it gets to the midfacial, I would still say even a lot of patients who come for midfacial, I generally refer them out to a higher center with MRI, to the KMC hospital that we have, the Manipal hospital. We send them out for an MRI because when it gets to midfacial, it's no more hard tissue. You're actually thinking of brain. So you want to image the brain with MRI. So I wouldn't say there are a lot of roles on midfacial really for CBCT. Hounds fields are not very accurate. Dose, of course, we just discussed saying, yeah, it's not really bad when compared to CT. So my take-home message for all of you, it produces great anatomic and accurate 3D images. You have better patient compliance, definitely less radiation exposure. It's very comfortable, very fast, very safe. So like 5-10 minutes and the patient is done with. Okay. With all that, I would still say from my perspective, it's definitely an essential diagnostic tool in current dental practice. That's what I understand. With all that I spoke, I don't know how long, maybe 1.5 hours or 1 hour or so. I would say two things for you if you can say. One, I hear, I know, I see, I remember. But with CBCT, trust me, if you don't do, you will not understand. You have to put your hands on it. Last point, a good doctor knows what to do and when to do it. But the very good doctor knows what not to do and when not to do it. And to CBCT again, it's so important to know when you should not advise it, right? Thank you all so much. CBCT, trust me, is very extensive and vast. So I'm just leaving you with my email there. If you have any doubts, queries, please one-to-one if you want to. If you have any specific queries, send me an email. I'll be very glad to reply to all of them. So with that, thank you, Akshata. Thank you so much. Thank you all for that patient hearing. If there's anything, I'll be happy to help you now.